let's start with, I think it's time now. So we are going to discuss chronic inflammation now. And by doing this chronic inflammation, we'll complete the whole topic of inflammation. And then we'll start with the repair process next week. So anybody give me a very good definition of chronic inflammation? What is chronic inflammation? Long term, okay, good. Okay, so as we were discussing before, if there is injury, and after injury, we start with acute inflammation, we all know. Why? Because the neutrophils are how much? About almost 65 to 70%, 60 to 70 rather. So these are the cells which are in a great majority in the blood. So this is the first line of defense. So whatever happens, neutrophils comes out first. And they cause acute inflammation. And you know that this inflammation is a short-lived, right? And it tries to overcome the organism. And if the organism is killed immediately, then they go directly to resolution. They don't go anywhere. But if the virulence of the organism is more, then they will go for more and more neutrophil, that is abscess formation. And in abscess formation, finally what happens? They go for repair process. Even acute inflammation, without going to the abscess formation, if it is delayed, even then they go to the repair process directly. If nothing happens, suppose the organism is so strong that it is not overcome by neutrophils, then the inflammation is a little bit prolonged. Usually acute inflammation lasts for 48 hours, 72 hours, 2 to 3 days, 4 days, maximum 5 days, not more than that. But if the abscess is formed, then probably it will take a little longer. But usually it stops there if the virulence is not that much higher. And if resolution takes place, you will not even find anything like something had happened. But if it is the virulence or the bacteria is something different, then the acute inflammation go into a chronic inflammation. So this is one way of going into chronic inflammation. But as I said, there are some organisms which does not bother to go to acute inflammatory process. Even they directly enter into the chronic inflammatory phase. There are some bacteria. They don't need. The best example is TB, tuberculosis. There are some fungi, there are some viruses, right? There are some materials which they enter in the body, they usually cause chronic inflammation. So they don't need acute inflammation. Okay. So as I was asking about the definition, this is the perfect and best definition. We have three things together in chronic inflammation. So an inflammatory process of a prolonged duration, as you said, weeks to months, sometimes years, in which inflammation, number one, tissue injury, number two, and attempt to repair coexist. Three things. If you say this is just a prolonged duration inflammation, this is not a complete definition of chronic inflammation. So if you talk about chronic inflammation, it will have inflammatory process, which is delayed type. Number two, it has a tissue injury. And number three, it's a repair process. In acute inflammation, there is an inflammatory process in tissue injury, but when the acute inflammatory process goes off, then macrophages come and they clean the area. So the process of repair is not going on coexisting. After the process of inflammation is complete, then the mononuclear cells or macrophages, they come there and they clean the area. But here, inflammation, tissue damage, and repair process simultaneously is going on. Why? Because it is a longer lasting one. It can take weeks to months to even years. So you had to have a repair process, right? So all the three things are going together. Anybody asks you definition, please kindly mention all the three things. If you miss anyone, you will lose your marks, okay? So it may, as I said, it may follow acute inflammation. So injury, acute inflammation, then comes the chronic one, or it may be insidious when the response is low grade without any manifestation of acute inflammation reduction. Time duration, definitely, it's greater than 48 hours in acute inflammation. Now, this 48 hours, you people always confuse. 48 hours doesn't mean exact 48 hours. It could be 2 days, 3 days, 4 days, right? But chronic inflammation, definitely it is more than 2 days, 48 hours. So it can be weeks, months, or years. It depends. Okay. Cell type in acute inflammation, what was the cell type? Neutrophils. So neutrophils was the cells which were taking part in causing acute inflammation. But in chronic inflammation, mononuclear cell like primarily macrophages, lymphocyte, and plasma cells. Lymphocyte and plasma cell play a very key role in chronic inflammation. They have a bidirectional movement. Lymphocyte triggers macrophage, macrophage triggers lymphocyte, and they play a role there, just like a table tennis. Pushes here, pushes here. The ball is going like that. Okay. Now causes. Definitely persistent infection. The organism is not easily been killed by acute inflammatory cells. So now lymphocyte and macrophages, they usually come there. Prolonged exposure to an insult, for example, silica, silicosis, a silica particle, or asbestosis, asbestos particle. Those persons who are working in these factories, sometimes they inhale silica particle or asbestos particle or beryllium particle. They develop this type of chronic inflammation. In asbestosis, you probably know or not, if they inhale this particle, somehow after 10 to 15 years, they might develop one cancer which is called, yes, which one? Not lung, it is actually a plural one. It's called mesothelioma. Mesothelioma. It's a very important one because, those patients working in that factory. So, but it starts with chronic inflammation, remember. Where while we were discussing the chronic inflammation, I'll tell you there is a specific thing which is called foreign body type of granulomatous inflammation, which happens here in this case. Then we have autoimmunity, like rheumatoid arthritis. This is a disease of usually an old people, an autoimmune one, and it usually lasts for years and years, right? Okay. So chronic inflammation arises in a various organ in three ways. Number one, as I said, following acute inflammation. Number two, after repeated bout of that acute inflammation like in pneumonias. And number three, without any prior acute inflammatory process directly like TB, viruses, silica. Why I'm doing it again and again? To put this thing in your mind. You should not forget, right? Now, histologically, chronic inflammation include lymphocyte, plasma cell, and macrophages. Acute inflammation, neutrophils. Sometimes we also include eosinophils in acute inflammation. Eosinophil can also be seen in chronic inflammation. So it can be a dual one. Then there is a proliferation of fibroblasts and small blood vessels healed by increased connective tissue. Then finally, replacement of the damaged tissue by macrophages and tissue destruction when macrophages, they engulf bacteria, try to destroy it, it bursts out and it causes tissue destruction. So this process of fibroblastic proliferation and newly formed blood vessels, we call this thing as a granulation tissue formation, which we will be discussing in our next week lecture, right? So this is very important, fibroblastic proliferation and newly formed blood vessels. As we were discussing last lecture, that in ulcer, the last layer is fibroblast and newly formed blood vessel. Now, as you all know, neutrophils are the cells of acute inflammation. But here, monocyte being immigration during the acute phase there and are then predominant cell after 48 hours. How many, what is the percentage of monocyte in blood? Yes. How much? Monocyte in blood. Neutrophil, you said 60 to 70. Monocyte or lymphocyte, okay. How much? These are the basic things you should know. Don't forget. Averagely, 60 to 70 neutrophil, 20 to 40 lymphocyte, 2 to 8 monocyte, 1 to 4 eosinophil, 0 to 1 basophil. You should learn this thing by heart, right? Nobody will give you a hint when you are standing in front of patient. The report will be in front. Maybe they don't have a normal values in front. You should know. For example, if the patient has neutrophil 78%, you should know, yes, there is some problem here. Neutrophils are more. If suppose monocytes are 12, 10, you should know, yes, it is more. Like in your PBL case, the monocytes were more, right? If you remember. Okay, so monocyte begins and it comes there after 48 hours. Why? Because they are a 2 to 8 in number, less amount in number. So first cell goes out is neutrophils and then lymphocyte and macrophages, because macrophage knows that the tissue is destroyed and when the tissue is destroyed, then we will go and clean up the things. In acute inflammation, they don't have any other thing in chronic in acute one. In chronic inflammation, yes. In chronic inflammation, you will see, if you see under microscope, you will hardly see neutrophils there. Neutrophils are gone then. It will be taken place by lymphocyte, macrophages, and plasma cells. So the macrophages is central to chronic inflammation. Now they have, macrophages have different name in different sites. For example, if the macrophage is in the blood, it is called monocyte. When it goes in the tissue, it is called histiocyte or macrophage. Or if it is in the liver, it is called Kupffer cell. So we'll discuss later on what are going on now. So they belong to a mononuclear phagocytic system, RES system, consists of a bone marrow, peripheral blood, and tissue. So these cells are belong to there. Mobility, definitely it's slow. Mobility is slow. It's not as fast as neutrophils. Neutrophils jumps like anything because they have to capture the organism first. Ability to become active, especially by lymphokines, which are secreted by definitely lymphocytes. So as I said, macrophage activate lymphocyte, lymphocyte activate macrophage, macrophage activate lymphocyte, lymphocyte activate macrophage, and then by this they start multiplying and dividing itself. So T cells and anything that disturb the cell membrane, this allow more aggressive behavior in inflammation. So the macrophage, which was in an inactive form, become more active, right? Activated by some cytokines secreted by lymphocyte. Now it is become more aggressive. The ability to secrete large quantity of chemical mediators. So all the things are mixing together. Chemical mediators, cytokines, lymphocyte helping each other. And then now they have made a plan that how to kill this thing. Now, if you have, remember one thing, if you have a good immunity, remember, the nature has provided you a best defense system. You may not need any antibiotics to kill the bacteria. There are few hospitals, even after operation, they don't give any antibiotic. Don't give. If they give antibiotic, then probably the surgeon will be called. Why? Because their sterilization process is so good. Normally in a low grade hospitals, the problem starts with sterilization, right? And then what they do, they start with antibiotic and then they perform operation and then they continue for 4 or 5 days that nothing will happen. But in a good institutions, the sterilization is so good that the bacteria cannot enter because of that sterilization process, right? Okay. Now this is how the monocytes goes. Starts from stem cells, bone marrow, form monoblast. From monoblast, it becomes monocyte. From monocyte, when it goes in the blood, goes out as a macrophage. Now, this macrophage, which is present in a CNS, will be calling microglia. When it is in the liver, it is the same macrophage will call Kupffer cell. When it is in lung, it is called alveolar macrophage. When it is in bone, it is called osteoclast. All of these are basically a macrophage, but it has a different name in different places. Clear? Okay. Now this macrophage will become activated by some cytokine secreted by lymphocyte. So initially, the macrophage or monocyte are not active, but they become active after reaching to that particular point, and then lymphocyte secretes cytokines and do that thing. Good? I think the things are clear now, up till now. You can stop me whenever you feel like there is a problem. Now, as neutrophil, remember, I'm not going in detail here. The monocyte comes out from the vessel exactly the same way as neutrophil does. So you all know in an axial flow, they flow in a center of the line. Then as there is turbulence, right? So axial flow is distorted. Now the RBCs are in the center because of the rouleau formation. And the WBCs are pushed towards the periphery, as you see here. Then first of all, they roll on the endothelial cells by selectin, E and P and E. Then it has been tightly adhesive by integrins, and finally they comes out. Then they reach to the point, and then if it is the inflammatory process, they divide into two. If they are being activated by lymphocyte to do the inflammatory process, so they will secrete interferon gamma, and then they become activated, and then they are more active in an inflammatory process, like reactive oxygen and nitrogen species are formed to kill the bacteria. Proteases, non-oxygen dependent one, will be more formed. Then cytokines, including chemokines, to help recruiting more and more lymphocyte there. Coagulation factor and arachidonic acid metabolites to help secrete more cytokines, chemical mediators. Now, if it is there for the repair process, which we will be discussing in the next week lecture, then there is again secretion of interleukin 4 and 5, which helps in some growth factor secretion from the macrophages, like growth factor, platelet-derived growth factor, fibroblastic growth factor, or transforming growth factor beta. They are being secreted by macrophages. Then fibrogenic cytokines are being secreted. Angiogenic factors like fibroblast growth factor, this is one of the angiogenic factor also. And then remodeling collagenase. Once the tissue has been repaired, it repaired little haphazardly, irregularly, then they have to remodel. They have to make it clear. If you might have seen the mason working for making a building, when they are doing plaster, they just throw the cement on it, right? That is irregular. Then they make it regular and smooth like this one, right? So this has been done by the last thing, collagenase. Okay. Function of monocytes, we'll do one by one. They produce toxic biological active substance such as oxygen metabolites to kill the organism by oxygen dependent type of killing, right? Number one. Number two, cause influx of cells such as macrophage and lymphocyte more and more. So secreting different cytokine, they are calling more and more cells to be there. Number three, cause fibroblastic proliferation and deposition there. And then finally, they phagocyte the organism which has entered, killing it. Three ways of macrophage to enter at the site. Three ways. How? Number one, They continued recruitment from the circulation, secondary to chemotactic factor. So the macrophages are coming from the blood vessels towards that point. Number one. Number two, division. Once they are there, they does not want more macrophages to come from air other side. They start dividing there and then, right? And number three, prolonged survival. Usually, what is the lifespan of macrophage or monocyte in the blood?
2 weeks.
No, 1 to 2 days only, macrophage. But once it goes out, do you imagine how much can it live? Months to years once it has come out. So definitely for surviving for months to years, they need some signals, and that is provided by cytokines. Okay, so this is the picture showing all the three ways. Number one, this is a blood vessel. So first is the macrophages coming from the blood vessel and entering into the site, number one. Number two, in this site, they divide itself without coming out from the blood vessel. They divide and multiply, number two. Number three, there are some cytokines which does not allow macrophage to go from here and increase the lifespan of the macrophage. So once the granuloma or the aggregation is formed, what will happen? It will remain there for years. Clear? Should I move now? Okay. So now the other cells, they are lymphocyte, plasma cell, eosinophils, and polymorphonuclea, which is neutrophils. They are basically, don't take this name there. I'm taking here because there are some exceptions, right? In which you can see some neutrophils there, but otherwise they are not present. I'll show you one of the, I have put one slide there and I'll give you the example. Lymphocyte. Again, they mobilize both antibody mediated and cell mediated immune reactions. We need to have both for killing of the bacteria, number one. Then antigen stimulated. How? By antigen presenting cell. As I said, this macrophage, they engulf the antigen, then they present to the lymphocyte, which is either effector or memory lymphocyte. And this lymphocyte recognize, oh, I have seen this thing before. Or if it is not, they start doing it. Because if it is already present in effector or memory cell, then the things start like this. But if it is a naive lymphocyte, which have not been exposed before, it takes little longer time to gather the things. You know this thing, and it will be done by Dr. Garvin in immunology lectures. So the lymphocyte of different type, T and B, both will be activated. Use various adhesive molecule and chemokine to migrate into the inflammatory cells. This means that they take the same route as neutrophil to come out. Same as rolling, adhesion, diabetes is going to the same direction. Okay. Then cytokine from active macrophage, mainly tumor necrosis factor and interleukin 1, and the chemokines promote leukocyte recruitment. You remember the neutrophil, that picture, right? How that TNF and interleukin 1 activate integrins, then histamine and thrombin activate selectins. Same goes on there. They come down, and then they also push some of the chemokines to attach with the protoglycan, and then they attaches with the neutrophils, which are down, and then the integrins, which are in the low affinity, will become high affinity, and then it will be tightly taken by adhesive molecule, ICAM, VCAM, and then it has been taken out. Repetition, and it is coming in your mind, right? Okay. Then lymphocyte and macrophages interact in bidirectional way. This is what I said. They stimulate macrophages, and then macrophages stimulate lymphocyte both. So this is very good picture. Try to understand. You don't have to go through the whole lecture. Just memorize this one. This is macrophage, this one. And this macrophage, they secrete interleukin 12 and also tuber necrosis factor and interleukin 1, which is then been stimulating this neutrophil to come out. But this one, first of all, it is antigen presenting cell. It present the antigen to the lymphocyte, T lymphocyte. Hmm? Now the things starts. If it is already a factor of memory cell, the things goes on quickly, right? They start secreting this number one, by interleukin 12 they are dividing more and more lymphocyte. Number one, lymphocyte, they secrete tumor necrosis factor and interleukin 17 recruit more and more neutrophils, and tumor necrosis factor more and more macrophages, right? And also this activated T cells, they secrete interferon gamma or gamma interferon. And this gamma interferon activate this macrophage. And now when it is activated in pathology, not probably in immunology, because Gavin was asking me, what is this epithelioid? What is this pathology you people are teaching student? In pathology, we call epithelioid. Why? Because this macrophage is looking like an epithelial cells, right? So in a pathology point of view, we call this activated macrophages epithelioid cells. Is it clear now? So epithelioid cell is an activated macrophage which has a capacity to kill the bacteria, even Mycobacterium. Why Mycobacterium is so difficult to kill? Have you ever thought it? Probably you will, I don't know, Dr. Atif is going to take your Mycobacterium tuberculosis lecture now or not. But let me tell you, Mycobacterium has a very thick wall, lipid wall. Have you done Zealand staining in the lab? What is the procedure of Zealand system? Why you heat that? Huh? I cannot hear you. Yes, very nice. The lipid wall, you had to break down that lipid wall. Suppose if you don't break down, at least you make some looseness in the wall, the lipid wall. By this, the carbon friction concentrated enters into the Mycobacterium. When it enters into the Mycobacterium, then you wash it with water. And then you put which stain? Methylene blue. Why? There is no function of methylene blue. Only you give this methylene blue for the contrast. Blue and pink is a very good contrast. So if the background is blue, you will be able to see pink organism. So what you do is, before putting this carbon friction, you put some acid, 20% sulfuric acid or hydrochloric acid. That's why it's called acid fast. When you put acid, you wash it, that carbon friction from the Mycobacterium. If it is Mycobacterium, the carbon friction will not be taken off. It will be strongly taken in, because after heating, you wash it. So what, the lipid wall become little weak or allowed the stain to go in. If you put the acid, which is 20% or 15%, something like that, it will not decolorize. And then you do the counter stain, which is methylene blue, and you see under microscope. If it is Mycobacterium, it will retain the color and you see a pink organism there, which you see in your case. You remember that case? What was that material which we have stained that acid fast? Was that sputum? What was that material which is showing acid fast bacilli? Remember the case, PBL case? You are going to discuss today. So from where we get that material? Yes? From the lymph node. Very nice. Because the AFB was negative in sputum, if you remember. While we take the FNSE, we saw the granuloma, a vaguely formed granuloma, elongated cell. Those elongated cells were all epithelioid cells, macrophages, right? And the acid fast was done on the smear, which shows pinkish material, right? There is one of more slide. So this is how it goes on and then this circle will be bidirectional. Lymphocyte activating macrophages, activating the macrophage activate the neutrophils, the lymphocyte, so goes on. Okay, lymphocyte macrophage display. This is what which we have already discussed, so just omit it. So this is, they present the T cell there, then you know the whole things are gone. Plasma cell, the other cell, develop from activated B lymphocyte and produce antibody directed either against the persistent foreign or self antigen. So you need antibody. Basically, if we are talking about tuberculosis later on, or in your case, which type of hypersensitivity is that? Hmm? Yes, 4. Why you are quiet? You have to discuss case today. I thought you must be very much prepared. Okay, so it is type 4 hypersensitivity. That is called cell-mediated type of immunity. Type 1, type 2, type 3, they are antibody-related one. Type 4 is cell-mediated. No antibodies are there. Only cell, which are mostly lymphocyte and macrophages, take part. That's called type 4 hypersensitivity. In some strong chronic inflammation reaction, the accumulation of lymphocyte, antigen-presenting cell, and plasma cell may assume a morphological feature of lymphoid organ uh, contain well-formed germinal center. So, for example, in rheumatoid arthritis or some other chronic diseases, you see this lymphoid follicles. Where do you see lymphoid follicles normally? Where do you see lymphoid follicles normally? There are two important areas where you see lymphoid follicle. Number one, lymph node. Number one. Number two, yes, spleen. Number three, small intestine. If you just see, there are lymphoid follicles present there. But this lymphoid follicle is present in a chronic inflammatory disease. They form themselves. This is called a tertiary lymphoid follicle, which is formed in delayed chronic inflammatory diseases. So this, they form here because now they don't need to recruit lymphocyte from the blood. They are making their own lymphocyte and the plasma cells and macrophages. They are tertiary lymphoid follicles. Okay. Eosinophils, as you know, they are abundant in immune reaction mediated by IgE and are in parasitic infections. The chemokine that are especially imported for eosinophils recruitment is eotaxin. Where did you read this? Have you heard this name before? Yes, while we were doing chemokines, and we have discussed 4 important chemokine, and the name was CXC, CC, C, CX3C, right? So these were the chemokine. This eotoxin is secreted by CC. Good, excellent. And the other name was CCL11. MashaAllah. Very good. What's your name? Tasneem. Good. Excellent. So eosinophils have granules. If you might have seen eosinophil, they have white, reddish or pinkish granules in eosinophils, and they have bilobed nuclei. They contain major basic proteins and highly cationic proteins that is toxic to the parasite. So that's why in parasitic infection, we usually see more and more eosinophil there. They are benefit in controlling parasitic infection, but eosinophils are also seen in allergic reactions. Allergic reaction like asthma. So as asthmatic patient, you might see more and more eosinophils. Okay. Then mast cells. You all know mast cells are distributed throughout the body. They are present in the connective tissue. They precipitate both acute and chronic reactions. In immediate hypersensitive reaction, IgG antibody bonds to the FC fragment of IgE bonds to mast cells, and they degranulate and they take out the substance which are histamine, and they cause anaphylaxis. And they also stimulate arachidonic acid metabolites, and they secretes prostaglandins. So this type of response occur in allergic reaction to food, insect venom, drugs, sometimes the catastrophe, for example, anaphylactic shock, when more and more histiocytes are being degranulated suddenly throughout the body. It's very important. In inflammation, there is only local vasodilation. What happens if the whole body becomes vasodilated? That is called anaphylactic shock. That's the reason why before giving any antibiotic, we usually do some test, skin test. That is called hypersensitivity 1. Within 10 minutes, you will get the result. And there will be reddish circle around that injection. That is type 1 hypersensitivity. In tuberculosis, we inject it, we get result after 2 days because the cells have to travel and go at that particular point. It needs more time. Cell mediated immunity. That is hypersensitivity. Why do you do it? Because the mast cells are present throughout the body. If you give antibiotic without testing it, and if the IgE attaches to the mast cell throughout the body, the whole body become vasodilation and anaphylactic shock. It's a very big catastrophe. Okay, then because of the secrete plethora of cytokines, many type of cytokines, they have ability to both promote to limit the reaction and of different situation. Now coming to the chronic inflammatory types, traditionally morphologically they are classified into chronic non-specific inflammation and chronic specific inflammation, which is called granulomatous inflammation. Why we call it chronic non-specific? Because we don't know what is basically a cause, a specific cause. So often they arise after acute inflammation or they be de novo, persist in when there is persistent injurious agent, diffuse infiltration of mononuclear cell, admixed with variable amount of neutrophils, and then finally the example of chronic cholecystitis because of the gallstones, chronic gastritis, chronic pyelonephritis, and chronic thyroiditis. So this is chronic cholecystitis. It's a gallbladder, and if you see, the lumen is filled with stones, right? And if you just see under microscope, you see this inflammatory cells in a low power. If you go a little deeper, they are mostly lymphocytes. Some of the macrophages are there, but predominantly it is lymphocyte. So there is no specific thing here. By looking at this slide, you cannot say which infection is this, which has triggered this thing. Only you can be knowing that, oh yes, probably the stones are there, but separated by which infection you don't know. This is gastritis. Again, normally if you take a sample of gastric mucosa, you will see a lot of chronic inflammation there, inflammatory cells. And this is basically a protective mechanism by nature, that they have a lot of chronic inflammatory cells in the submucosa and mucosa. But when it becomes active, as I said, sometimes you see neutrophils also. So you see neutrophils in the lining epithelium here, right? So if you see neutrophil in this lining epithelium, then you call it this the same thing as chronic active gastritis. Chronic active gastritis. You will not say acute and chronic. No, the name specifically given is chronic active gastritis. Clear? Okay, uh, then we are here for chronic specific inflammation. As you all know, that why we call it often granulomatous inflammation in nature, and is dominated by cell mediated immunity type 4, as you said. So there is definitely mostly it is reaction of facultative intracellular organism with persistent T cell response, and it is Mycobacterium and some fungi which cause this. So immune mediated disease like Crohn's disease, inert indigestible foreign material like suture, prosthesis, silicone, what you call asbestos, beryllium. So these are all things which can cause this one, inert digestible, and the disease of unknown etiology like sarcoidosis. So they can all cause granulomatous inflammation. So the basic example of granulomatous inflammation is tuberculosis, which we have this case of today. So this is a definition of granuloma. What? A type and pattern of chronic inflammation defined by the presence of granulomas, which are 0.5 to 2 mm in diameter, and they have a collection of modified epithelioid or histiocyte macrophages, and they have multinucleated giant cells which are called Langerhans, not Langerhans. Remember, it is not Langerhans, it is Langerhans type of giant cells, which is actually the histiocyte when they comes together and form one giant cell, Langerhans type, usually surrounded by a rim of lymphocyte. Clear? Clear? So any granuloma which you see, you will see all these features. Now this is how the granuloma is formed. Remember this picture and you will not forget. So this is the antigen presenting cell. So this will be what? Macrophage. Very nice. It could be macrophage, it could be mast cells, it could be dendritic cells, right? They are all antigen presenting cell. But now we are discussing about macrophage, right? Make yourself focus. So this macrophage has taken up this bacteria, and then they have presented this to the antigen, the lymphocyte. Now, not only presenting it, but they are, because this bacteria has also activated this macrophage slightly. So they have secreted interleukin 12, and this interleukin 12 helps in proliferating lymphocyte also. So more and more lymphocyte. Now this attaches here, then they secrete tumor necrosis factor, which recruit more and more macrophages, right here. They secrete interleukin 2, which promote more and more lymphocyte to come out. They secrete interferon gamma. What will they do? They activate this macrophage, interferon gamma. Don't forget interferon gamma. This interferon gamma, when it changes to macrophage into, these are all epithelioid cells. Remember, epithelioid cells are not a different cell. It's the same activated macrophage. If somebody say activated macrophage, his answer is right. We just pathologists, because it looks like epithelial cells now, that's why we are calling it as epithelioid cells. Clear? Okay. So this is a granuloma. This is epithelioid cells. Some of the epithelioid cells, they combine together and form these giant cells. This is called Langerhans type of giant cells. The importance of this Langerhans type of giant cell is it has a nucleus in the periphery, and usually it looks like a horseshoe. The cytoplasm will be in the center. I'm not drawing it. Other giant cell, the nuclei are haphazardly placed in the center. These are foreign body giant cells. And if you see it clearly, you see some of the diffractile item present in the center. Let's draw with the red one. Diffractile, either it is a suture, either it's an asbestos particle, either it is silicone, beryl, whatever. Right? Clear? This is foreign body giant cell. The nuclei are present in the center. The third one is Chuthon giant cell. I'll show you in the picture. In this, they are forming garland, necklace. So there is cytoplasm outside and there is cytoplasm inside. A peculiar picture, typically like this. And the fourth one, which is not mentioned here, it's a tumor giant cells. Tumor giant cells, don't make you confused, but the cells are hyperchromatic, larger in number, showing pleomorphism, hyperchromasia. There is a difference between these cells and these nuclei and these nuclei. This malignant one, right? Tumor cells. Is this slide clear to you now? You need something more? No? Okay.
Pardon me, doctor.
Yes.
We can't see what you wrote on the board very well.
Okay, no problem. I'll be showing you in the slide. I'll showing you the same thing in a slide. I have a slide of that also.
Okay, thank
So
you.
the granulomas, the a granuloma is a focus of chronic inflammatory inflammation, consists of microscopic. This is the same thing which I have drawn. Microscopic aggregation of macrophages that are transformed into epithelioid-like cells surrounded by mononuclear lymphocyte and plasma cells. It is in the usual hematoxylin and eosin tissue sections. The epithelioid cells have a pale pink granular cytoplasm with indistinct boundaries, often appears to merge one another, right? And I'll show you the slide how it looks like. Remember, the macrophages will be little lighter in color as compared to the lymphocyte. And while we'll be discussing the picture, I'll show you. Okay. Granulomas, the nucleus is less dense, as I said, the epithelioid, than that of a lymphocyte. So they are the nucleus of this epithelioid cell will be elongated, just like a slipper which you usually wear. So it is elongated, and in your PBL case, FNAC, and you see a lot of elongated cells in the center, right? Then we have lymphocyte, a rim of lymphocyte. Then we have a rim of a fibroblast. So it is forming a full granuloma. So epithelioid cells can fuse together and form one giant cell, which I have made there, and I'll show you here in the picture. Those are online. We'll see those ones, and they have a diameter of 40 to 50 micrometer, and these cells are called Langhans type of giant cells when they are present in TB granuloma, or a foreign body giant cells as you are seen in the foreign body, which I have shown, or xanthogranuloma. And these are the online students. Please kindly concentrate. This is what I have drawn in this board. This is Langhans type of giant cell. The cells having a nuclei in the periphery, and in the center you have eosinophils, right? And this is a foreign body type of giant cell in which these nuclei are present in the center. And this, the refractile material, a shining material, is probably a suture which has been taken. And if you just polarize the light, it will sharply reflect the light. That's why it is reflecting this one or these two one, right? So these are the foreign body. It could be asbestos particle, it could be silicon particle, it could be beryllium particle, it could be suture, whatever, foreign body. Or the third one, which is two-tone, you can see it is forming a garland or a beautiful necklace, uh, diamond, rubies. So the nucleus will be arranged in circular manner, in which you can see that the cytoplasm will be inside as well as outside. So this is a two-tone giant cell which you see in xanthogranuloma. Okay. So these are the three one. The last one which I mentioned in a board is a tumor giant cells, which we are not going to discuss here, although it is a big cell, but the nuclei will be larger in size, showing hyperchromasia and pleomorphism. So that will be absolutely different, right? So just forget it there. Now coming to the diseases, how you will classify this granuloma, chronic granulomatous disease. Tuberculosis, which is caused by Mycobacterium tuberculosis; leprosy, which is caused by Mycobacterium leprae; syphilis by Tripolima pallidum; cat scratch by gram-negative bacilli. Then we have sarcoidosis, which has unknown etiology; schistosomia, it's a parasite which causes problems; histoplasmosis, which is a fungal infection; foreign body like asbestos, silicone, or suture, whatever. And then finally, Crohn's disease. When you will come in third year, we'll discuss Crohn's disease. It's an inflammatory bowel disease. It's a immune reaction against the intestinal bacteria, and it is also it's a self antigen which causes this disease. Okay. So now Mycobacterium, because it's a prototype of granuloma. So we discuss Mycobacterium. Dr. Atif was saying, why are you discussing this tuberculosis here? We have a full tuberculosis topic in third year while we'll be doing respiratory system. I said, okay, go ahead, do it there. So I'm not touching the lung now. That's why I took, this case is written by me, right? So we have taken extra pulmonary lymph node enlargement. So we have not touched the what you call lungs. So this extrapulmonary, although it is coming from the same way, but it is taken up by the lymph node, and the lymph node is been enlarged, right? The whole thing, the whole Mycobacterium topic, the whole treatment, Dr. Dilip was saying, oh, if you start this, then we have to teach them the tuberculosis drug. I said, no, don't teach. We'll just look, put a single line that anti-TB was given and the patient become all right? So that's why we are not touching the anti-tuberculosis pharmacology. We are not touching the bacteriology, and these two will be definitely being taught to you in third year completely. Okay. It is often characterized by presence of central caseation necrosis. In contrast, caseation necrosis is rare in other granuloma. The morphological pattern in a various granulomatous disease may be sufficiently different to allow a reasonable accurate diagnosis to pathologists. For example, it may be necessary to identify the specific antigen by specific stains, like you did acid fast for Mycobacterium, tuberculosis. You can do culture, like for TB, which culture you do? No, culture. It's LJ media, Lewinston's Johnson's media, specific made for bacteria. For fungus, it is Loeffler's media, which you do culture for the fungus. And you also do molecular techniques like PCR for tuberculosis. Now, these are the pictures, which is, please, you online students, this is a gross picture of the lymph node, right? You see this whitish area. So probably it's a caseous material which is there. Caseous means cheesy material. So this is a very low power in which you see 1, 2, 3, 4, 5, 6 multiple granulomas, right? Small size. It's why it is. I have taken this picture because you should remember it is 2 mm, 2 micron micrometer, not bigger one, to form granuloma. And this is the high power picture of this granuloma. And this is in the center, you see this caseation necrosis. Then these are epithelioid cells, this one, right? And they have elongated nuclei. And you can easily, these are all epithelioid up till here, right? You see this dark color one? These are all lymphocytes, rounded lymphocyte. These are Langhans type of giant cells, as I have drawn there, and in your picture, the nuclei are present in the periphery, right? Usually it is mostly a horseshoe type. Hello, put your mobile down. I have given you full opportunity. You are fully authorized to enter my class. You are fully authorized without asking me, leave the class. But while you're in my class, I want your full attention, please. You can stop me anytime. But if I see something doing, that hurts me. Okay, so this is Langhans type of giant cells. Okay, then finally, this is furthermore close-up of that picture. And here you can see a well-formed giant cells. So this giant cells, Langhans giant cell is not different, but 20 to 30 or 40 macrophage, they join together and form one cell, right? So it does not have a very distinct cell boundaries. These are elongated cells, right? These are all epithelioid cells, elongated one. So this is the difference between the true histological picture and the FNA slide which I have provided to you, right? So in your PBL case, those elongated cells in the center were all histiocytes. And you probably might have seen, or you might have been told today, or they will tell you that there is a vaguely formed granuloma in the center, right? If somebody has opened it, I'll show you here. A vaguely formed granuloma forming in that picture, right? And the rest of them were small rounded cells. They are all lymphocyte. So there are lymphocyte, there are histiocyte, you have one granuloma, the joint cell. By looking at that picture, we call it TB. For further confirmation, we have made a smear We did AFB stain that was positive for AB, and that confirms that we are dealing with tuberculosis. Clear? I hope you, by having this lecture, you will discuss more in the class. Remember, these PBLs are very, very good for you to make yourself. And remember, don't be quiet. Nobody will say anything. Jump in. Say as much as you can. Because if you do mistake, you will be cleared. And the concept in your mind will be more and more cleared. If you keep quiet, you will not understand. Please jump in PBL. When I was conducting PBL, I was demanding each and every student to say something. Okay? PBL are very good thing to, This is another slide, and in which you can see this is all amorphous pinkish material. This is caseation necrosis. Now, what is caseation come from? The same histiocytes, which are activated macrophages, they are epithelioid cells. When they kill bacteria, they burst itself. So what is inside material, it comes out, and they form like a cheese. So more and more histiocytes, when are they killed, they are put inside. Some of the bacteria are killed, some of the bacteria are not killed. So they form a granuloma. They form a circle. They put their hand together, and they does not allow this caseation to go out. Right? This is a blessing from Almighty Allah, that He has given us this opportunity, that organism which are not been killed by histiocyte, it should remain in that focus. It should not go out. So they held themselves tightly. So this histiocyte make a circle. It is surrounded by the lymphocyte, and then finally the last is the fibroblast. So they make a full circle like this, and they don't allow what is going on inside should go out, and it should disseminate in the body. Then you will ask why it has entered into the lymph node when it has been. This is an antigen presenting cell, macrophage. It has engulfed that bacteria from the respiratory tract, and then it has been taken to the nearest lymph node, right? From the antigen presenting cell to it activate lymphocyte, and then itself it goes through the lymphatics to the neighboring lymph node, and now it is trying to kill that bacteria, and that's why more and more inflammatory process is going on in that particular area. It is not allowing other lymph node to be involved. If your immunity is good enough, the whole organism will be killed, and you will be having free of bacteria, free of tuberculosis. But something happen if suppose the immunity is not good, then the same bacteria will go back into the lung, and it will infect the and cause pulmonary tuberculosis. And tuberculosis can be anywhere in the body, in the brain, in the lung, in the whole GI, anywhere you name it, and it is there. Okay. I think this is the last slide which we're discussing. Outcomes, yes. So resolution, regeneration, restitution of the normal structure. After doing everything, they try to maintain the thing. Although it has taken longer time, 2 months, 3 months, 4 months, 1 year. But finally, they try to restore the thing. Repair, organization, healing by connective tissue, fibrosis, scarring. And it can be continued indefinitely, like in rheumatoid arthritis, and it's coming and going. You give treatment, it becomes all right. You stop treatment, it starts again. So this is lifelong. Rheumatoid arthritis cannot be stopped. So this is what we have discussed about chronic inflammation. Any questions from the class, from online, from the class? Any question from? Yeah.
Do you have any tips for midterms?
Midterms. For midterm exam, I will not say that only look into my lectures. Remember, we just take points from the book, right? So what I'll say, if you have enough time, then you can open Basis Robbins, which is a bigger book. But if you want to be concise, even basic Robbins, 9th edition, now 10th edition is there. So you can see, because it's a slight difference. Otherwise, there is no change. So, you can open this book. And remember, I will advise you, because I have made your lecture in such a way that if you open my lectures and open the book, it will be going along with the flow of the stream. So it will be just helping you. You will be remembering my words while you were opening the lectures. And now the lectures are being recorded, right? So if you just open my recording and open the book, and it will be like flow of the stream. Thank you very much. Anything else?
Doctor, any topics I should focus on?
No, because I have taken questions from every topic, starting from the introduction lectures. So I will select the question 2 or 3 from each and every topic. So don't think that you are focusing in one topic. No, whatever lectures I have given to you, I will take 2 questions to 3 questions from that one to make the whole paper. Okay, thank you very much. Yeah.
What are the systemic symptoms of chronic inflammation?
Systemic ones are okay. I think we have discussed this thing already in our acute inflammation. There are systemic like fever, like raised ESR, like increase in the C-reactive protein. Like there are 3 proteins most commonly which is raised. One is C-reactive protein, fibrinogen, and amyloid. C-reactive protein and amyloid, they also act like opsonin. The fibrinogen, as I said, when you take, why the ESR of the person is raised, because this fibrinogen, they attach with the RBCs, they form a rouleau formation, they become more heavier, and they settle down more. So the reason why this patient has raised ESR is because of that fibrinogen, which is also systemic effect. So in systemic effect, you can have leukocytosis, and sometimes this leukocytosis is so big that you can call it as a leukemite reaction. Usually, you know that the WBC count is from 4,000 to 11,000, and if it crosses 11,000, which is 12,000, 15,000, 20,000, it is leukocytosis. But if it is raised up to 40,000, 50,000, we call it leukemite reaction. In leukemite reaction, then you see some band type of cells, which is immature neutrophils. We call it shift to the left. So this is all stated in your Robbins book. And this is the last page of inflammation. If you open it, on the whole systemic reactions are mentioned there. Yes. That's all.
Yes.
And one thing, and the last important thing, my office is always open for everybody, even in-house, this one who are sitting here, or online student. If they are not clear, they can email me or they can come to my office anytime. There is no time for students. I am always available. Okay, thank you very much.
Yeah, Dr. Bennett?
I think I have taken it. Okay, thank you. Oh. Thank you. I will upload this thing on Moodle just now, right? I'm going to my office. Or do you have access?
No.
No, okay.